So that's just one organization that's took the next generation model and integrated it with their critical care unit and their palliative care initiative, and took this on as a systems improvement process, which has significant outcomes not only for ethics but for the organization, but definitely has ethical components to that in terms of how these issues are addressed, that we know what patients want in terms of advanced directives or their values, that we're responding appropriately, that decision making, whether it's usually by the surrogate, is one that's not conflictual with the organization, etc. So I want to do quickly just tell you what we're doing this current year and then open it up for questions. Last April we had a system ethics forum. We have it every other year, and our focus was on disparities and inequities in healthcare delivery. We were paying particular attention to end-of-life care. At the conclusion of that forum, we decided to commit our fiscal year 08 focus on next generation to addressing disparities and inequities in patient care. And the reason why, from an ethics perspective, was our commitment to social justice. That if there's a certain population receiving a level of care that's different from another population simply based on race, religion, ethnicity, ability to pay, we said that's just it's inconsistent with Catholic social teaching and not something that we want to be part of. So we set out in 2008 that every one of our organizations would have a project, an ethics improvement project, focusing on disparities and inequities. We also linked it to two of our system strategic initiatives, which are excellence in the care experience and diversity and inclusion. This is one example of a project from our hospital in Ann Arbor, Michigan. And they're just sort of getting it together. But their approach was this, is when they investigated where there might be disparities based upon race within the organization, what they found initially was questionable data about how race is determined at the time of admission. And that sometimes the admission coordinator simply looked at the person and checked the box on race. It wasn't self-identified race, it was projected race. So we were probably off the mark significantly on what race people are and how they identify themselves. So I'm not sure, that might be something you want to investigate in your own places, is how is that data collected at the time of admission in your own facilities. Secondly, they know, we're looking across our organization around CHF and diabetes and inequitable treatment. We're addressing those in our community benefit ministry, but also we have, like many of you, system benchmarks for CHF and diabetes. This initiative is looking at 2 or 3 clinical areas, of which 2 of them are CHF and diabetes, and seeing where there are discrepancies of care based upon race within the organization, and what's the national benchmarks telling us about this, and to try to target our deficiencies in those areas and to improve them. So they haven't done anything other than right now they're trying to determine what criteria, if they're going to use the IRS that determines, is that where we get our current list of differentiations between race? Equal Employment Opportunity Commission. No, I think across the country, Census Bureau. That's what we're looking at, and I don't think that they want to use necessarily that data because they don't think it's as representational as it possibly could be. So anyway, that's one project that they're looking into. Another one that's looking at an improvement opportunity along the lines of disparities and inequities is, once again, St. Mary's in Grand Rapids. What they discovered was when they looked at where there might be disparities, and they were looking already at diabetes care within community benefit, what their data showed them was that in the private physician offices, I think 64% of people who were treated for diabetes had annual eye exams, and in their clinics, it was like 8 or 12% annually. So they identified that as their ethics improvement opportunity in terms of addressing a social injustice. And what they set out to determine the first year is if they're going to move we have a system benchmark of 50%, so the private paying population in the physician offices were actually higher than our system benchmark. The clinic population was significantly lower than the benchmark. From a matter of justice, where should they set the target for the first year? Because it's currently 8 to 12%, and the private pay population is 64%, should they at least move it to 32, which was half as well as the insured population? As the conversation went on, do you think that's justice to say, oh, the poor, it's okay to give them, sort of keep them at 32%, where the paying population is at 64%, and the system benchmark is 50? They ultimately decided we have to put the benchmark at least at the system benchmark of 50%, and if that's what we're measuring ourselves against, it shouldn't make any difference whether you can pay or you can't pay. So that's where they're headed. Now, the interesting thing that sort of the wrinkle that came into this approach was that they were hoping to get volunteer optometrists to do the reading, and they actually needed ophthalmologists to do the readings. Finding volunteers to do that is a bigger challenge. But this is still their goal. So after 5 years, where are we? Ethics is more anticipatory in focus. I think we're thinking much more ahead, trying to identify issues that haven't really surfaced as significant issues yet than we did before. We're better integrated within each one of our organizations than we ever have been. Ethics quality improvement opportunities are often linked to our strategic plans and key organizational or system initiatives, which really get senior leadership to buy into ethics improvement. If you're talking the language of the strategic plan and the initiatives of the organization, you get the support much more quickly of senior leadership. Activities of ethics are quantitatively and qualitatively measured and reported. So we do have measurable outcomes for all of our projects. And with that, I'll just conclude and open it up for any questions or comments that you have.